there are some people coming in from the University City campus, so we really appreciate that. And before we start, I also want to thank you, College of Nursing and Health Professions, and all the support that they have provided to make this event happen. Personally, to Dr. Palisano and Darren, without them, this collaboration cannot happen. So ScholarShare is a monthly seminar that features graduate student research. If you are a graduate student and want to participate in ScholarShare, you can find the sign-up sheet on the Graduate College website. At the bottom of this page here, there's a link for you to sign up to be a presenter. So today, our moderator is Dr. Margaret Finley. She is from the Department of Physical Therapy and Rehab Sciences. She is a PT and a PhD. She teaches courses in the Doctor of Physical Therapy, Doctor of Health Science, and PhD in Rehab Science programs. So without further ado, I want to introduce Dr. Finley to come up here to get started. Thank you.
Well, first, thanks for having this here. It's nice to have you guys on the other side of the pond, but to bring you guys to this side of the campus and get our students actively involved with y'all as much as possible. This is, I think, a great platform for you guys to be able to share your work at various stages and get feedback from your colleagues, as well as from some of these presentations are in areas that are somewhat familiar to some of us, but are give us some new background as to what all is going on in our college, university as a whole. So my job is to introduce the speakers as they come up. Are we set to flip over on this? And she is that one. Yes. So that should be her, and then I'll let you come and start it up. Okay. We've got this, and our first presenter is Julia Rivera, and she is a master's student in the Department of Nutrition Science. She's going to talk to us about their work in the comparison of fitness characteristics in collegiate and master's athletes.
Thank you. Thank you, Dr. Finley. Let me get this started. Okay. Hi, everyone. My name is Julia Rivera, and as Dr. Finley said, I'm a graduate student in the Department of Nutrition Sciences. And today I'd like to share with you a study that I've been part of at Drexel called the Comparison of Fitness Characteristics in Collegiate and Master's Athletes. And I've been a research assistant for this study for about a year now, and it's a very unique and exciting experience. So a brief study overview. The principal investigator is Dr. Stella Volpe. Some of the aims of the study include comparing resting metabolic rates of athletes, comparing aerobic fitness and physical activity levels of different athlete types, comparing body composition characteristics of athletes, as well as a dietary intake. The study originally began in 2013. It is a cross-sectional study. There's no intervention, and we have about 430 participants at this time. So our participants include healthy individuals, 18 years of age or older. We have split it up between collegiate athletes and masters, collegiate meaning 18 to 25 years old, or masters 26 years of age or older. And they lead an active lifestyle, and they exercise 2 or more days a week, and they are non-smokers. So we are collecting a number of data, and we use a variety of tools to collect these data. So the type of data that we're collecting include resting metabolic rate, thermic effective activity, dietary intake, body composition and bone density, VO2 max, or maximal oxygen consumption, as well as height, weight, and waist circumference. I won't necessarily be touching on these 2 areas just because a lot of us know how those are measured, but I'll be going over the tools for each of these. The first one is the indirect calorimetry metabolic cart, which we use to measure resting metabolic rate. So on your right is the hood, which we place on our participants, and it analyzes gas exchanges to determine resting metabolic rate, which is how much energy they need just to be alive for a 24-hour period. Likewise, we provide them with an accelerometer, which measures the thermic effect of activity, and it'll track and measure activity over the course of 7 days. These two together, the resting metabolic rate through indirect calorimetry and the accelerometer, measuring the thermic effect of activity, and as well as the thermic effect of food calculation, will determine their total energy expenditure, which is how much energy they use on average at the current period of their training on average per day. We also utilize a food frequency questionnaire, which is a 110 food item questionnaire and analyzes the type of food, quantity, and frequency of intake. And with this data, we can estimate intake of macronutrients, micronutrients, energy, and different types of food groups available. Body composition is measured with two different tools. The first is the bioelectrical impedance analysis scale. You might see this at the gym. It is able to measure body fat and hydration status, but has a higher standard error than the next tool that we use, which is called the dual energy X-ray absorptiometry, or DEXA scanner. And this is what we have this on the second floor here in this building. The DEXA scanner has two levels. If you're not familiar with how it works, has two levels of X-ray photon energies. One energy is absorbed easily by soft tissues, the other primarily absorbed by bone, and it is considered the gold standard. It is able to measure lean body mass, body fat, bone mineral density, and the standard error, as you can see, is much lower, about 3% compared to the BIA. It is considered the gold standard. And on the right-hand side, you can see the scan output, which shows the outline of the body, the bone density, as well as tissue composition. Green being lean mass, yellow meaning adipose, and red is deeper adipose tissue. If you can see that, I don't think you can. Lastly, the next tool that we use is the VO2 or VO2 max. It's actually through the indirect calorimetry metabolic cart. It's a mobile cart, and we measure aerobic fitness through a cardiopulmonary exercise test. We are able to determine the greatest amount of oxygen consumed and utilized by the participant's cell. The higher the value, the more aerobically fit you are. Again, we use mobile technology for this. Okay, so when I first began in the lab, there were many different questions running through my head of how we could actually use this data and research. Some questions were like, do athletes get enough energy to support them during training and competition? Are there significant differences in body composition between athlete types? What factors influence bone health in male and female athletes of different ages? And what kind of effect do training and nutrition have on body composition, aerobic capacity, and bone density? So when I started learning more and more about research, I found that these questions were way too broad. So I decided to hone in on bone density. So my thesis concentrates on vitamin K and calcium intake in athletes and the relation to bone mineral density. So bone formation, growth, and repair is dependent on the interactions between vitamin K, calcium, proteins, and enzymes in bone. So the study will evaluate the intake of these macronutrients and the association with bone mineral density from the DEXA scans. And ultimately, I would like to see if there is a ideal or a calcium to vitamin K ratio that is associated with ideal bone mineral density. Maria Terry is also another master's student in the Department of Nutrition Sciences, and she's evaluating the differences in dietary intake in calcium, magnesium, and zinc in these in the athletes to the recommended daily allowance. And the focus for her is that these micronutrients play important roles not only in bone and tissue metabolism, but energy production and fat oxidation and exercise recovery. Finally, Joe Stanzione is our PhD student in the Department of Nutrition Sciences, and he's been the most prolific with these data so far. He has a number of different analyses and studies. For example, evaluation of lean body mass as a predictor of dietary protein intake, and his dissertation will be focusing on sport-specific substrate utilization during VO2 max test consumption. And finally, I'd like to thank Dr. Volpe. Through this study, Drexel students, including myself, have been able to learn how to conduct research, as well as provide an avenue to explore fitness characteristics in athletes, and hopefully provide ideas for intervention studies or dietary guidance for athletes, or even contribute to our research community. Thank you very much.
Open this to questions from people. Start at the very end, we're all free. Well, then we won't do it. That's where I missed out my time. Hold your questions. Hold your questions. What are you going to come up? Okay. So now we'll go. Now I'm up because there's a second presentation. That's why I'm here. That's fine. Sarah, I believe you're up, correct? Is that our order? Sarah or Travis? Travis, thank you. I wasn't sure what our order was going to be here. All right. I'll pull this up. Did I hit the right button? All right, there you go. Travis, I think, check if that's how you want your screen. Our second presenter is Travis Pollen. Travis is a PhD student in the Department of Physical Therapy and Rehab Science in our Health and Rehab Science PhD program. And he's going to present his work on how to exercise more without getting hurt.
All right, so just by a show of hands, who in here has done a 5K or a half marathon or any sort of endurance event? Okay, now how many of you got hurt while training for said event? Okay, a few people. So quite common, and I'm going to talk about some ways that in our training we might be able to reduce our risk of injury. So there's a paradox in injury prevention research where we know that to maximize our fitness level, we have to train a lot. And so personally, when I was in college training for swimming, I was doing upwards of 15, maybe 20 hours a week of training in the pool, in the weight room. And that's pretty common for athletes in college and professional ranks. The paradox is that when you train more, that also increases your risk of injury. And so this has been shown through several sports and levels of play: rugby, Australian football, baseball, and youth athletes all the way up through semi-professional and professional. So that leads to the question of how do we maximize fitness if the more we exercise, the more we get hurt? And another way of thinking about that is there a way to maximize fitness without increasing our risk of injury? So this guy right here is named Tim Gabbett. He's an Australian sports scientist. He has 2 PhDs, so you know you can trust him. He's the preeminent researcher in this area, and he, in 2016, came out with a model of athletic injury that seems to have a solution to this paradox. So like I said before, high training loads tend to lead to high fitness, but they also lead to increased injury risk. And on the other hand, if we minimize training loads, that can end up leading to poor fitness because we're not doing as much, which can also increase the risk of injury because of the poor fitness. So what Gabbert proposed was this idea of the sweet spot, somewhere in between low and high training loads that will still lead to high fitness while decreasing the risk of injury. And so I flash up the Goldilocks and the 3 bears here because it's not too much, it's not too little, it's just right. But then how do we know what that sweet spot is? Well, in this literature, there is a way of quantifying the sweet spot, which is usually done with this value called the acute chronic workload ratio. So the way that's calculated is you take the previous week of training, so let's say it's the miles you ran leading up to your 5K, and you divide that by the previous month of training. So what that would look like visually here would be an example of a low acute to chronic workload ratio. So the 4th week's training is a lot less than the previous 3 weeks, and you wind up with this ratio of 0.6. On the other hand, you could have a high acute chronic workload ratio, where in the 4th week of training, where the 4th week of training is a lot more than the previous 3 weeks. And then you could have a sweet spot ratio where the 4th week of training is just a little bit more than the previous 3 weeks. And so these numbers actually come from a review paper that Gabbett did, where he looked across cricket, soccer, rugby, Australian football. And this plot is the likelihood of injury versus the acute chronic workload ratio. So what he found was that there's this U-shaped curve where the risk of injury is minimized in the 0.8 to 1.3 range, and then the incidence of injury greatly increases as you get up above 1.5. So he called that the danger zone. And what he recommended was that athletes stay in this sweet spot zone so that they can gradually progress to higher and higher chronic workloads, which will minimize their risk of injury and increase their fitness. So like I said, that relationship was shown across several sports, but one sport that it hasn't been looked at is swimming, which is my area of research. So swimming is a particularly interesting population to look at with this, because they sustain a lot of overuse injuries. And it has been posited that overuse injuries are very much load related. And so they might be able to be reduced if we modify the loads. There is cross-sectional data showing a relationship between amount of training and injury, but there's only one prospective study that was done on this topic, and they actually found no relationship between the training loads and injury. But that could have been because they were asking for the athletes to report their individual training, and only 15% of the athletes did. So they just used average data from the team for the rest of the athletes. So we have to interpret the findings from that study with caution. One of the aims of my research is to look at the relationship between training loads and non-contact musculoskeletal injuries in competitive swimmers. And my hypothesis is that the timing of non-contact musculoskeletal injuries will be strongly associated with spikes in acute chronic workload ratio. So I have a study currently underway where we will look at 59 college swimmers prospectively. So we'll track them over the course of their season, and we will have the coaches report their training load. So the coaches will tell us who's at practice each day and what the team did for practice that day. Injury we're defining as any non-contact musculoskeletal pain, either acute or overuse, that resulted from team activities and prevented the athletes from participating in at least 50% of practice or a competition. And so the reason that we define it that way is because we don't want to only include athletes that had to miss a whole practice, because in swimming, the culture is that you swim through pain. Pain is normal. So we would miss those people. So we softened the definition a little bit, but we didn't want to say, well, did anybody have pain over the course of the season, because almost everybody has pain at some point over the course of the season, but it might not modify their training. So here's what that sort of data will look like. This is actually from my own 2010-2011 swimming season. So you can see the number of yards that I swam on the y-axis and the day of the season on the x-axis. It's about a 200-day season, 30 weeks or so. And here's the acute chronic workload ratio for each day. And so you can see that most of the acute chronic workload stays around 1 plus or minus 0.3. But there are 3 spikes here, here, and here, or 3 regions of spikes where the acute chronic workload ratio was above 1.5. And so luckily for me, I didn't sustain an injury at any of those time points. And that could be due because one of the limitations in this type of quantification of workload is that it doesn't factor in the athlete's response to that workload. It's just an external measure. And so it could be that when those spikes occurred, it was more overall yardage, but the intensity of that yardage was easier. So in order to characterize that, you would need to measure the athlete's response either through heart rate or rating of perceived exertion. And so while the external workload is an important measure, it doesn't tell the whole story. The way that I will examine the relationship between workload and injury is that I'll calculate a 2x2 contingency table with injury as the one factor and workload as the other, and I'll compare high workloads versus workloads within that sweet spot and calculate a relative risk from that. I mentioned just before that one of the limitations of the total yardage is that it doesn't also include a measure of the athlete's internal response. There are other reasons why we might not be able to predict injury perfectly, and that's because injury is multifactorial. So athletes have certain predisposition for injury based on what their previous injuries have been, their age, sex, the way that they move, psychological factors too. And so all of those are factored into an athlete being susceptible to injury in conjunction with being exposed to external risk factors like training load, which is the one that I've been talking about, but also things like sporting equipment, playing conditions, coaching, opponent behavior in some sports, to a certain extent in swimming, but a little bit less because you're not directly contacting them. But then for an injury to occur, the predisposed athlete who is exposed to external factors experiences an inciting event or a series of inciting events in the case of an overuse injury that finally leads to the injury. So training load is just one piece of this bigger puzzle, which also doesn't even take into consideration an athlete's nutritional profiles, how much they're sleeping, interpersonal relationships, their academic demands, travel. So all of these things can contribute to injury, and even though training load has been shown to be important, it's not the only one. My research, in addition to training load, is actually looking at previous injury and biomechanics and the way that those all interplay in the development of injury. So just to recap, spikes in acute chronic workload ratio have been associated with increased injury incidence. Sweet spot acute chronic workload ratios might be the solution to this paradox. So this is really as simple as tracking, if you're a runner, how many miles you've run each week, and doing this acute chronic workload calculation each week to see if you're staying in the sweet spot or if you're exceeding it. It's still to be determined whether this relationship holds up in other sports like swimming, which I'm going to be hopefully answering that question with my research. And even though training loads and spikes in training loads are an important risk factor, it's not the only one that can contribute to injury. Here are my references, and we'll take questions at the end. Thank you.
All right, let's pull up our third one, and this one is Sarah. Don't like when things go blank with me here. All right. Let's see when I have this goes blank. It says it's going. There it is. All right, great. All right, so for our third and final one this afternoon, we're going to have Sarah Gleason coming up and talk to us. She is a PhD student in material science, and she's going to talk to us about designing artificial bone and nanoscale modifications that mimic biological structure. So we're going to change gears a little bit, I think.
Hi, everybody. So like it was introduced, I'm going to be talking about less about injury prevention and more about injury treatment in this case. So in my research, I take biological concepts and engineering design concepts and try to merge them together to create artificial bones. So bone injuries are obviously very common. I'm sure everybody knows someone that's broken a bone before, and they generally heal themselves. But if the trauma is large enough or severe enough, then the bones actually aren't just going to heal themselves with something like a cast. So in cases like that, the most common treatment for this type of bone injury is to use something called a bone autograft, where they actually harvest bone from another site in your body and implant it into the damaged site. So while this is a relatively effective treatment, and it's really common, it's used all over the world, there are some issues with it. And these include the fact that you need a second surgical site to actually harvest that bone from your body. Also that you have a restriction as to the size of bone that can be used for that new implant, and also a really high risk of infection, in part due to that second surgical site. So what we need, and what's being looked at with a lot of research, is whether we can have a less invasive but equally effective treatment for healing these bone injuries. So currently, the most commonly used artificial bone material is a ceramic bone cement. And this is something that can be injectable into an injured site, and is generally made up of calcium and phosphate ions, which are similar to the components of your actual bone in the body that I'm going to be going into in this presentation. However, whenever you're considering using an artificial bone material, you have to, obviously, since it's a skeletal and structural function in the body, you have to consider how mechanically it's going to perform. So this graph here shows on the x-axis the modulus of different materials, and you can kind of think of this as a measure of strength. And then on the y-axis is going to be fracture toughness. So this is a measure of how brittle something is. So for these ceramic bone cements, they fall into this range on the graph right here. So you can see that while they're very strong, they're going to be really brittle. So you can kind of think of these as like a coffee mug, right? Where if you drop it, it's going to shatter, and it may not be great for use in your body. And actual bone that you'd find in the body is this red region here on the graph. So you can see that while it has the similar strength characteristics to that bone cement, it's going to be a lot tougher. And what this means is that it's going to be much less brittle. So a lot of current research is looking at incorporating polymers into the mix. And polymers you can kind of think of as plastics. They're really long chains of molecules. And the key is, even though they're not as strong, they have toughness values that are going to be more on the order of what you'd find in bone. So the idea is that by combining these ceramic components and the polymer components together, we'd be able to come up with a composite material that's going to behave much more similarly to what you'd find in the body. So in my research, where we're approaching this problem is we're thinking that if we can mimic bone structure, we'd be able to scale that up into something that's then going to replicate bone's properties also. So bone in general has a lot of different levels of structure, all the way from a whole bone down to individual molecules. But what I really care about is the nanostructure of bone. And at the nanoscale, bone generally has two components. One is going to be this ceramic phase that has these calcium and phosphate ions in it, similar to that ceramic bone cement. And the other component is collagen, which is a protein that forms these fibrous bundles that make up your bone. And together, these two components fit together into something that's depicted in this schematic, where you have these gray collagen fibers, and interspersed in bands within those collagen fibers, you're going to get this mineral phase. So together, these create a really complex composite material that obviously is serving people very well in their bodies. So our goal is to try to mimic this structure. A lot of research is being put into seeing if we can start with collagen as a foundation, introduce this mineral phase into it in order to recreate this bone structure. So you can see it's been pretty successful. So this is someone's research where they were able to remineralize collagen in a lab, and you can see that it looks very similar to what you would find in a natural bone from the body. However, there's a lot of disadvantages to using collagen. It's very expensive, and it's also really difficult to process. And the difficulties in processing gives you a lot of variability in the size and the structure of what the result can look like. So it's something that may not be feasible to use in actual medical applications. So what I'm looking at is, can we use a more efficient polymer, and one that we can create in a lab to do the same thing as we can see here. So what I've decided to use is I use a polymer as my foundation that we call polycaprolactone. So it's this blue end of the chain here. And polycaprolactone is cheap, it's really easy to process, and it's biocompatible. And it also has a neutral charge to it. And then what I do is I connect another segment onto the polycaprolactone that we call polyacrylic acid, and it has a negative charge to it. And the key to this negatively charged section is that when we introduce these calcium and phosphate ions in solution. So we put it in a body mimicking environment. The negative charge actually attracts the positively charged calcium ions, and those then recruit phosphate ions. So we can direct exactly where the mineral is forming by where we have these negatively charged domains. So it gives us a lot of control over exactly what structure that mineral and polymer interface is going to be taking. And so through this, we can create these directed composite structures that we think have a lot of potential to be used as artificial bone. So what this looks like in our structures is something called a Nanofiber Shish-Kebab, and hopefully you'll see why we use that name for it. But we start with this bicomponent polymer fiber that has the neutral and the negatively charged ends on it. And then we incubate it along with these neutrally charged polycaprolactone nanofibers. So you can see here, this is a scanning electron microscope image of those nanofibers, and they're only about 200 nanometers in diameter. So they're really small and on the order of something you'd find in bone. And when these two are incubated together, the bicomponent polymer actually crystallizes onto the surface into these repeating kebabs that we call them, with these fibers being the shish. And you can see that it forms these actually lamellae of negatively charged and neutrally charged regions. And you can see this is what it actually looks like when we take pictures of it. So you can see kind of these backbone fibers, and then we get these big kebab sections that form on the surface. And this is important because when we put it into our ion solution to mineralize it, the ions actually only preferentially are going to go to these negatively charged domains. So what we get are these really carefully, locally contained regions of mineral that form. And so you can see here in this picture that even though there's mineral in this, you can't really see it, and that's because they're actually contained to only the domains that we want them to be. So this is a really big step in trying to get something that creates that very carefully organized collagen or polymer and mineral interface that you'd find in natural bone. So the more recent work on this project is looking at kind of going a step past this really basic model of what a bone is. So I was talking about how a bone has two components, the mineral and the collagen component, but in reality, bone in your body is going to have a lot more complicated environment than that. It's not just ions and polymer and mineral. There's a lot of other things going on. So to take the next step, we're starting to look at what is the role of non-collagenous proteins, so other proteins that aren't going to be collagen, and how they're going to influence this process. So in your actual body, these proteins have a lot of different roles. They can inhibit mineral forming, they can promote mineral forming, they can kind of recruit ions to them, and they all work together to make this actually a very complex process, whereas it was very simplified in the slide that I just showed. So our question is, can we use a similar system where we can introduce artificial polymers in here to kind of mediate this mineralization process in something that would be a little bit more biomimetic? And so this is work that's very recent, and we're just kind of brushing the surface of it, but has a lot of potential. So we start with our kind of straightforward, very simplistic mineral process. So we start with our shish kebabs, and we just put them into an ion solution. And if you were to incubate this with a relatively high ionic strength of ions, what you get after 5 days is something that looks like this. And so this doesn't look anything like those shish kebabs, and the reason is that we actually have several microns of overgrown calcium phosphate ceramic here. So all these plates are just ceramic material. So this isn't great because we've lost that entire control and the interface that we were going for in the first place. So our idea is that we then just introduce some more of this negatively charged polymer, but instead of keeping it in our structures, we additionally put some into our ion solution. And the negative charge here will serve to kind of create these hydrated polymer ion clusters. So it'll kind of attract all of these different mineralization ions to it, and it'll have an inhibitory effect as well as helping, we hope, to deliver the ions in a controlled manner to our structure. So after 5 days in the same solution with a little bit of this negatively charged polymer added, you can see this is the result. So this is much better. We still see that shish kebab structure that we had, and we don't see a ton of uncontrolled overgrowth. But you can see from all the roughening here that we definitely still have mineral that is being introduced into this system. And then it's also very tailorable. So just by increasing the concentration of this polymer in solution that we use, you can see here, this is a shish kebab structure that's been mineralized again for the same amount of time, but we don't see any mineral here. So just by tuning something as simple as the molecular weight or the concentration of this polymer that we add, we can have a lot of control over the kinetics of this mineralization process. So this is something that's really exciting for us to be able to look at maybe different ways of really controlling every facet of this process and something that's more biomimetic. So in conclusion, we think that we've created something that is kind of a stepping stone towards us being able to really design complex bone mimicking nanostructures. We have a material that's composite, it's easy to process and inexpensive, so we think it has potential in the future to maybe be scaled up into something that's really usable. And we hope that one day it's going to totally eliminate the need for any sort of bone harvesting and instead could just be used as an implant into the site of an injury. So thank you very much for listening to the talk.
Bring them up, or do they just, okay, you guys come on up. And we'll just open the floor for questions. So if you can, people have questions, Rick, I have mine here, so I'll let you guys go first. Question.
First thing, like, all did really nice presentations. For someone who, when you're not an expert, sign of a good presentation is that you made it clear, and you all did, so that's great. And now, the beginning of the first name?
Sarah?
Sarah, I'm sorry. So Sarah, this is pretty, I was interested, I was wanting to peer into your electronic microscope. It's pretty cool. How would you progress this? It seems like, as someone who's not knowledgeable, that you're looking to see if you can create the material as that comes to fruition. How would you progress that toward, would it be progressed towards ultimately a human application?
That's the hope. So actually, kind of ironically, I'm doing the opposite, where I'm taking a tiny part of that and delving into smaller scales. But we have done some pretty basic studies of looking at mechanical properties of these. So instead of looking at the really small scale, we've kind of built them up into something that you can handle. And we've done some pretty straightforward mechanical testing on them. And we've found that we do actually see an improvement in strength and toughness when we can mineralize them. So I think the next step in making this something that was more applicable would probably be really delving into tuning that mineral content and the mineral kinetics, and then connecting that to what we see in terms of mechanical properties. Before probably the step beyond that then would be thinking about the form it needs to take. So it might be chopping these up as like a filler into an injectable cement, for example. So then we have that as its matrix, because right now they basically just form kind of films. So I think first step would be looking at mechanical properties just for practicality, and then the next step would be looking at like exactly from a more realistic standpoint how we're going to get them into the body themselves.
Follow up to that up. So the physical therapist of lessons from the same questions. So from here, do you all hand this off to others to take it to animal model, to humans, or do you see it all the way through that translation to that shoulder that it's implanted in, or whichever bone structure you're looking at?
Yeah, that's interesting. I guess that I thought we would do most of the materials testing component of it, but any sort of more animal models would probably be with some of our collaborators. We have another lab that we work with that does some similar work, and they do a little bit more of the animal side of things. So I have a collaborator who's doing a lot of cell studies right now. So it's not like an in vivo study or anything, but he's seeding cells onto the surface of these and seeing the response of those. So I think he would probably send it more in the animal study direction.
Other questions out here?
My question is for Chad. So you mentioned that swimmers often swim through pain. So for your study, how are you going to identify what a true injury is if someone is swimming through pain just because of fatigue or injury? Like, how do you distinguish that?
So we have two methods of tracking the injuries. The first is for the coach in her weekly reports to say this person had to miss competition, or this person was forced to miss or modify 50% of practice. 50% threshold was, we had previously asked from last year, based on this definition, how many people would classify as injured, and it was about a quarter of them, which was just right. It wasn't none of them, it wasn't all of them, and that was helped with the power analysis to find that like a reasonable number of people, because you want to have a good proportion of injuries. So based on that definition, we expected to get a similar finding this year. Preliminarily, I can say that the coach hasn't reported a lot of injuries to us. So as a result of that, I've also contacted the participants directly, and largely at times where they were away from school because they were training on their own, so they have a fall break. I just contacted them over winter break, asking them how much training they were doing, but also if they had sustained an injury. And so I've gotten more reports trickling in because I said, have you sustained an injury no matter how minor? And then if they said yes, I hit them with a lot of questions. Did it cause you to modify practice? Did you seek medical attention? Have you had this injury before? So I can address it at all levels, like any pain that caused them to fully stop practicing, or that 50% threshold. And from a statistical standpoint at the end, if I don't have enough injuries based on that definition, I can modify it.
Or another question.
With these polymers going through the region, and you showed, I think they were at 58 for 5 days, and they tried to formulate a nice shish-kebabs. If you were to leave it for 10 days or 15 days, would they continue to mineralize outward, or does it stop at that nice structure that you showed?
Yeah, so that's a good question, and that's kind of why we're looking into even adding that negative charge. So if we use the right, you can change a lot of factors here. So if you use the right ionic solution, like concentration-wise, you can actually get something where after 5 days, even with no added polymer, it looks kind of like that nice one that I was showing you. But then as you keep mineralizing it, it'll continue to grow outwards and outwards until it kind of obscures the whole structure. So that definitely would happen. And so kind of what we're looking into next is if we put these inhibitory things into it, is that going to prevent it from ever growing outwards beyond that point, or is it just going to delay it? So the question would be, whereas with no polymer, we see that after 7 days, we see that like uncontrolled overgrowth. So the question would be, is that not going to happen at all when we add this extra polymer in, or is it just going to take, a month to have it happen now?
Based on what you know right now, is this something that you see forming in a lab and then implanting into somebody, or is it something where you could implant the right strands in something and let it minimize?
That's a great question. I personally think I see kind of getting the mineralization going in a lab and then implanting it, because I think it would probably be able to be a little more biocompatible if we could have it be more similar right off the bat. But the idea is that it would then promote all the bone forming cells to actually just start like depositing more and more like new bone on top of it, kind of at the same rate that it was degrading. So we see it as kind of getting it to look like bone in a lab, being able to put it in and then have it just go right into the formation and bone uptake process.
We're trying this again, kind of off the last one first. When you say miss 50% of the practice, is that also modifying the practice? And then do you think, just from my own observations and experience, do you think you're getting more reports over winter break and such because will be more willing to modify and admit to injury when a coach isn't watching them?
Well, so presumably these athletes are training with like their high school or club team while they're home. But it could be that their relationship is different like there, that allows them to be more open and honest about needing to modify practice versus maybe the culture within the college team and the relationship with the coach dictate that they don't, that information isn't getting to the coach.
Yeah, I just because I've seen people say to a coach, I think I should fight or something, and the coach says, "This is really you." And it just turns to a point in some cases where people just won't say anything because they're more concerned about.
Yeah, well, that was, so I was observing a lot of the practices and noticing that there were people who were sitting out, and then at the end of the week, the email wasn't coming to me with their names. And so I thought maybe I need to address this, directly from the athletes. And on the one hand, now I have, people selectively, but just not answering my emails. I'm getting maybe 90% response rate. So it's just about piecing those together. But ultimately, we're most interested in the injuries that cause modifications to practice because we think that affects performance.
Does that be potentially someone online having a question?
No, it's just somebody else joining us.
Okay, let's just make sure we didn't forget our fellows online.
If somebody asks a question, they'll type it into the chat and I'll
Great, thank
raise the
you.
question.
Thanks.
So far, no questions.
Great, thank you.
I have a question about the X-ray technique. So it seems like you get a lot of data, right? You can understand things about that and the bone, and to me, like that's like super daunting as experimentalists saying, "Oh my gosh, I have all this data to analyze." You guys use any computational tools to help you with that, or is that like a side goal of your lab, or like how do you keep that analysis consistent between people?
Right, sure. So yeah, there is a lot of output from that kind of data. You can see how much fat you have in your right arm versus your left arm. So for the aims of the main study, we're really just focusing on total bone density, body fat, as well as the density in your lumbar spine and your femurs. So we are limiting exactly what we'll be looking at. But for example, Joe, a PhD student, he at some point, or he's able to delve into those data even deeper if you would like to, and make an analysis out of that. But for my thesis particularly, I'll be looking at total bone density, but there is that potential to go in even more if we wanted to. So.
I want to follow up on yours, because you had said from the very beginning that, and I've actually seen the masses coming in the elevators. You can tell when people put them on day-to-day. They're collegiate and master's athletes. The definition of an athlete, are they people that are actively competing on a team at the collegiate level, and same for your master's athletes?
So our definition of an athlete is someone that's active 2 or more days per week, and we have it's a very wide description because we would like to analyze all different types of athlete levels or like activity levels.
Okay.
So we do have collegiate athletes that are just necessarily part of the club, or general athletes versus professionals. So we do have a wide range of different types of athletes. It's anyone that's really moving 2 or more days a week.
And that follow-up on that one is, in thinking of Travis, is there any information on, are they in season, out of season, where they are in that season when they're doing these food logs and you're taking these body fat and bone density measures?
Sure. So we do categorize them as part of being really professional versus club versus recreational. And then we do ask them if they're currently competing in their sport of choice, and they can answer yes, they are, or no, they're really just working out for the time being, out of competition and just training in general. So we do have the delineator in our data.
Question about this. You showed that curve where you're looking at the ratio versus somebody that injured. Did I see it correctly? It actually goes up if the ratio is less than, I think it was like 0.8, something like that?
Yeah, so there's also some thought that if you're training very little, or if that acute chronic workload drops very low, then that's also increasing the risk of injury, because now your fitness is potentially poor.
But was that curve just for overuse injuries, or was that all injuries?
That, it was a mix.
Okay, so that increase in injury rate with a low training rate could be possibly like they're just weak to their sport and key injuries.
Yes.
Okay.
It was a mix of sports.
That makes more sense.
Yeah. There has, so that graph has been proliferated a lot since it came out in various editorials and consensus statements. There's been some questions surrounding it in terms of how they combined the different sports, how they fit that curve. So that they don't talk a ton about what's going on at that lower end of it, but that is the correct deduction from that, which is those really, if you're very low in the acute chronic workload ratio, that also increases risk.
So as that curve shows relating injury rates and training time, how does that compare to the impact that training has on performance? So optimizing performance is what a lot of exactly for the machine. I'm just wondering where are the spectrum that happen? How different, for example, sprint swimmers versus swimmers?
Sure.
Is any?
Well, so the basic idea is that having a high chronic workload is going to enhance performance. So the whole idea with the model is how do we get athletes to high chronic workloads without exposing them to acute workloads that they're not prepared for. And so a lot of the papers will look at the timing of injury compared to just chronic workloads, just acute workloads, or the acute chronic workload ratio. And you can analyze that so many different ways, and every different study chooses different ratios for that, which sort of muddies the comparisons between them. But the idea being that the injury is most associated with this acute chronic ratio, and goal being to minimize the injuries so that you can progress athletes to higher chronic workloads, which will enhance performance.
I'll follow up on my question for Travis. You had said that you're going to also be getting the biomechanical measures of your swimmers. Is that during swimming or post-injury? Is that?
So we collected biomechanical data on all the swimmers in the first month of the season. We looked at land-based movement in the first week, and then we were just attending practice and watching them swim over the first 3 or 4 weeks.
Observational. You had also brought up one comment during your thing that looking at some of the spikes and injuries that had to do with moods and attitude. Are you throwing any psychosocial stuff in?
Yeah, so because of the number of participants I have, I can only look at so many variables, but in their preseason questionnaires, I also asked them 5 questions about their perceived susceptibility to injury, as well as how much they feel like they have control over whether they get injured. And so that was just a quick and easy way, as opposed to, there are some sports anxiety questionnaires or life stress questionnaires that are 70 items long, and they have a nice association with injury, but because of all the other information I was asking about injury history, I didn't want to burden them. So I just asked them these 4 quick questions. And it could be that athletes who perceive themselves as being at greater risk get injured more, or it could be the opposite, that these athletes know what the risks are and are being mindful of modifying them, and they end up getting less injured. So the research has been shown to be gray in that, so it should be a good addition, at least from an exploratory standpoint. Look at that.
All right. Any other questions? Well, good. Thank you all. Excellent job, everybody.
There's plenty of food left in the bag, so I hope everybody get a chance to grab a bite. Thank you everybody for coming in.
And before you go, just a quick thing. We have our next week's Tuesday topic is guiding principles when teaching across disciplines, which is really geared mostly for teaching faculty, for people who aspire to be teachers. It might be something for you to take a look at. And then 2 weeks from today, we're hosting and discuss focused on America's Inside Out with Katie Couric. It's sort of a video book club. We're going to watch a video, and then we're going to come together and we're going to chat about what we saw and the issues that came up for us. And it'd be really great to have everybody sort of participate in this if you're able to. Anyway, thank you so much for coming. Thank you to the Graduate Student Association for their wonderful presentation.